Assalamu alaikum. Now, today's topic is ectopic pregnancy, a very high-level topic for the upcoming exam. Start with this. Before jumping into this, I would like to tell you a definition of ectopic pregnancy. Like ectopic pregnancy, in which blastocyst implant in a location outside the endometrium of the uterine cavity. What happens that blastocyst implant in which a blastocyst implants in a location outside the endometrium of the uterine cavity. The most common site is fallopian tube. The most common site is fallopian tube, but it can occur in other locations such as in ovary, in cervix, or in the abdominal cavity. So it can be cervical, so it can happen in cervix, it can happen in abdomen, it can happen in ovary, and it can happen in the fallopian tube. This is the most common site of ectopic pregnancy. It's a medical emergency and leading to cause of maternal morbidity and mortality in early pregnancy. So early diagnosis and treatment is needed to prevent internal hemorrhage and death. If we look at the risk factors, of ectopic pregnancy, one of the most high risk factor is prior ectopic pregnancy, prior pelvic or tubal surgery, and PID. That means most commonly in here, the sexually transmitted infection like happens due to chlamydia or Neisseria gonorrhea. Chlamydia and Neisseria gonorrhea, it can cause direct ciliary damage. And with ascending infection, ciliary damage and ascending infection, and thus causing these salpingitis, that means involvement of the fallopian tube, inflammation of the fallopian tube, thus causing PID. So prior ectopic pregnancy, prior tubal or pelvic surgery, and PID. the if we look at the clinical features, you have to remember a triad of the clinical feature. What is present in the triad? One is amenorrhea, second is unilateral lower abdominal pain, and third one is vaginal bleeding. So amenorrhea, unilateral lower abdominal pain, and vaginal bleeding. These three things present in um, ectopic pregnancy. So classic triad of ectopic pregnancy is amenorrhea, followed by lower abdominal pain, amenorrhea with and vaginal spotting in the setting of positive pregnancy tests. Presentation, it is present at 6 to 8 weeks. Of gestation and is typical, uh, like amenorrhea as unilateral lower abdominal pain. It develops unilateral lower abdominal pain. These abdominal pain develops as a fallopian tube become increasingly distended. The pain is described as crampy, or sharp, severe abdominal pain, and may indicate the tubal rupture. So, in hypovolemic shock in rupture pregnancy can happen. In rupture pregnancy, hypovolemic shock can happen. And there is vaginal bleeding. Look at these vaginal bleeding. So these three: abdominal pain, amenorrhea, vaginal bleeding. This is the triad. And hypovolemic shock in rupture ectopic pregnancy, and cervical motion and adnexal and abdominal tenderness is present with or without palpable abdominal mass. And in here, vaginal bleeding, the third cause, vaginal bleeding occurs due to sloughing of early decidualized endometrium. The endometrium begins decidualization under the control of the progesterone from the corpus luteum. Bleeding is often light spotting rather than heavy bleeding. There is light spotting rather than heavy bleeding, often seen with spontaneous abortion. Okay, and patient with rupture pregnancy, like in rupture pregnancy, can come with severe abdominal pain, hemodynamic instability, shoulder pain. In here, one important is shoulder pain due to referred pain from diaphragmatic irritation, because diaphragm has a nerve supply C3 4, cervical 3 4, and shoulder has same dermatome C3 4. So uh, referred pain can happen from diaphragmatic irritation by intraperitoneal fluid. On pelvic examination, there may be cervical. In pelvic examination, there may be on pelvic examination there may be cervical motion tenderness due to presence of intraperitoneal fluid. And rare presentation can happen, like ovarian ectopic pregnancy, interstitial ectopic pregnancy, cervical ectopic pregnancy, and abdominal ectopic pregnancy. Ovarian, uh, ovarian ectopic pregnancy, abdominal ectopic pregnancy, cervical ectopic pregnancy, and interstitial ectopic pregnancy. What are our differential? If we find a case with ectopic pregnancy, what should be our DDs? When you find a case, you have to find out the DDs differential. One is threatened or missed abortion. One is threatened or missed abortion. Second one is high dead ED for mole like gestational trophoblastic disease. There may be adnexal pathology, and non-gynecologic cause like acute appendicitis, diverticulitis, and kidney injury. Okay, now what? How we can diagnose this patient? Like diagnosis positive beta-hCG and transvaginal ultrasound revealing abdominal mass, empty uterus, transvaginal ultrasound revealing adnexal mass and empty uterus. So for patients with vaginal bleeding and positive beta-hCG, a transvaginal ultrasound should be performed. There are three scenario may be present. Normally developing pregnancy, maybe too small to be seen. Alternatively, if a pregnancy is seen within the uterine cavity, threatened abortion and threatened abortion should be ruled. That may be threatened abortion. An ectopic pregnancy is ruled out if there is some product in the uterine cavity. So ectopic pregnancy rules out. With an imaging finding that includes a complex adnexal mass separate from the ovary with or without gestational sac with surrounding vascularity, like a ring of fire, like a ring of fire sign on Doppler ultrasound. If you find a ring of fire sign on the Doppler ultrasound, looks like ectopic pregnancy. And a spontaneous abortion can happen if the uterus appears in empty in the setting of pain and bleeding. A complete abortion may occur. So three scenario may be found on transvaginal ultrasound. Okay. The interpretation of the transvaginal sonogram is dependent upon the quantitative beta-hCG level. A level between more than 2500 to 4000 is minimum required for an ectopic pregnancy to be seen within the uterus, and known as discriminatory zone. These 2500 to 4000, like 2500 to 4000 is a discriminatory zone. In the setting of unclear imaging and low beta hCG level, that means pregnancy of unknown location, a repeat beta hCG and transvaginal ultrasound should be performed every 48 hours. Transvaginal ultrasound should be performed every 48 hours. It will be discussed in the detail in later part. Okay, diagnosis. Then the management. If the patient is stable, methotrexate. If the patient is unstable, surgery should be done. Okay, management should be discussed in detail in the later period of my lecture. Okay, what is the likely diagnosis? What is the likely diagnosis in hemodynamically? What is the likely diagnosis in a hemodynamically unstable patient with a gestational sac? Hemodynamically unstable patient with a gestational sac in the intrauterine convoy and a free fluid in the posterior cul-de-sac on transvaginal ultrasound. It is rupture ectopic pregnancy. It is rupture ectopic pregnancy. That is a cornual or interstitial ectopic, a cornual interstitial ectopic pregnancy, also known as cornual ectopic pregnancy, often presents as abdominal pain and vaginal bleeding. Okay, management in detail in here. If you find look with magnifier. If you find positive urine beta hCG, if you find positive urine hCG, positive urine hCG, lower abdominal pain with or without vaginal bleeding, then you have to look at the patient is hemodynamically stable or not. If the patient is hemodynamically stable, then you should do transvaginal ultrasound. In transvaginal ultrasound, there may be three interpretations. There may be adnexal mass. If there is adnexal mass, treat ectopic pregnancy. If it may be intrauterine pregnancy. In transvaginal ultrasound, there may be intrauterine pregnancy, and it may be non-diagnostic. So we are unable to find out what, we are unable to get the conclusion. Then you should do serum beta hCG level. If serum beta hCG is more than 3500, if serum beta hCG is more than 3500, repeat beta hCG with or without transvaginal ultrasound in 2 days. If it is less than 3500, repeat beta hCG level in less than 2 days. So in hemodynamically stable patient, first do transvaginal ultrasound. If it is inconclusive, go for serum beta hCG level. If it is more than 3500, again do serum beta hCG, again do beta hCG along with transvaginal ultrasound. And if it is less than 3500, then you should do only the beta hCG. If the patient is hemodynamically unstable, immediate surgical intervention. Immediate surgical intervention should be done. Okay, look at here. Methotrexate is contraindicated in patient with hepatic disease or renal disease. Methotrexate is contraindicated in patient with hepatic disease or renal disease. That is diabetic nephropathy due to decreased clearance and slower drug metabolism. Due to decreased clearance and slower drug metabolism, increase the methotrexate toxicity. Early but viable intrauterine pregnancy. Early but viable intrauterine pregnancy, more than 35 to 50%. More than 35 to 50% rise in beta hCG every 48 hours. More than 35 to 50% rise in beta hCG. In viable or early but viable intrauterine pregnancy, beta hCG should rise 35 to 50%. incomplete spontaneous abortion, beta-hCG will decrease. In ectopic and non-viable intrauterine pregnancy, less than 35% rise. So these three is a very high thing you need to remember, the beta-hCG level. Okay, methotrexate. We know that methotrexate is a folate antagonist. It inhibits cell proliferation by interpreting DNA synthesis, and it is one of the treatment options for these hemodynamic stable patient with an unruptured ectopic pregnancy. But not every patient is eligible for methotrexate therapy. If the patient contraindication like breastfeeding, like hematologic, renal, and hepatic abnormality, pulmonary disease, peptic ulcer disease, or immunodeficiency, concern for rupture, coexisting with intrauterine pregnancy like heterotrophic pregnancy, and inability to follow up for beta-hCG level. There are relative contraindication to beta methotrexate therapy are conditions that make methotrexate less efficacious and increase risk of treatment failure, alike if beta-hCG level is more than 5,000, if there is fetal cardiac activity, and ectopic mass more than 3.5 centimeter, then it is the relative contraindication of the methotrexate therapy. If beta-hCG level is more than 5,000, if there is fetal cardiac activity, and ectopic mass more than 3,500. Methotrexate methotrexate management requires close surveillance and follow-up with serum beta-hCG level to ensure resolution of the ectopic pregnancy. A baseline beta-hCG level is drawn on the day that the methotrexate is administered on day 1. Levels are then drawn on the day 4, day 7. Beta-hCG level should drop by at least 15%. Drop should be needed uh, when you start methotrexate on, then you should see on day 4, on day 7. They are followed weekly on resolution. If the level drops less than 15% at any point, a repeat dose of methotrexate is administered. If the patient has contraindication of methotrexate therapy or hemodynamically unstable, then surgical treatment is required. For patient with hemodynamic instability, hypertension, diabetes, syncope require urgent surgical management. Most often laparoscopically, surgical management involve salpingostomy, like incision of the fallopian tube, removal of the pregnancy, and salpingectomy, removal of the fallopian tube, Okay, to distinguish between this ectopic pregnancy and non-viable intrauterine pregnancy, patient must undergo diagnostic TNC, a procedure that samples tissue within the endometrial cavity, and it is confirmed by post-procedure beta-hCG level. Post-procedure beta-hCG level. A negative beta-hCG confirms that a non-viable pregnancy, non-viable intrauterine pregnancy, and these patients require reassurance and observation only because the products of conception have been removed by uh, DNC. A persistent beta-hCG rise after DNC is diagnostic for ectopic pregnancy. Persistent beta-hCG after DNC um, is diagnostic in ectopic pregnancy. Uterus has been evacuated, but the extrauterine pregnancy continues to produce beta-hCG, and these patients require additional management and methotrexate. A progesterone level less than 5 nanogram per ml. A progesterone level less than 5 nanogram per ml suggests abnormal or extrauterine pregnancy. This is very high yield, you need to remember, but more than 25 nanogram, a progesterone level less than 5 ectopic to more than 25 intrauterine, healthy intrauterine pregnancy, healthy intrauterine pregnancy. Okay, how can you prevent ectopic pregnancy? Like a prompt treatment of the STDs to prevent PID, smoking cessation, and careful management of the fertility treatment to minimize the risk of ectopic implantation, and use of contraception reduces the overall risk of ectopic by preventing conception. Okay, now some questions. Let's dive into some questions. Okay, first of all, this question. Look at this patient. 16-year-old girl, nausea, vomiting, lower abdominal pain. One point I have found: lower abdominal pain. There is crampy lower abdominal pain, crampy lower abdominal pain, and periodic sharp stabbing sensation. Okay. There is vaginal spotting. Okay. Crampy abdominal pain, vaginal spotting, and there is menarche 13. Okay. Blood pressure normal, pulse 78. There is tenderness. So we have found she has lower abdominal pain, she has vaginal spotting, she has vaginal spotting, and she is unsure of her last menstrual period as it was regular. So looks like amenorrhea. And there may be tenderness to palpation, adnexia, tenderness to palpation of the left lower quadrant of the abdomen. Which of the most likely explanation of this patient's condition? It may be developing blastocyst implanted in the extrauterine location. As for definition of the ectopic pregnancy, blastocyst implant outside the endometrium or uterine cavity. So developing blastocyst implanted in extrauterine location, it means ectopic pregnancy. So this system, as it is abdominal pain, vaginal spotting, and patient is unable to know her last menstrual period, looks like ectopic pregnancy. So it is ectopic pregnancy. Um, so I am in this. Now I will not gonna read the explanation. Look at this picture. This is ectopic pregnancy. This is tubal implantation, ectopic pregnancy, embryo, endometrium. Okay. Okay, what are the other location? I have already seen, we have already seen this picture. Okay. And this is the tubal rupture. This is fallopian tube, ampulla of Vater. This is a rupture. This is stomach. This is uterus. Okay. Look at this question now. Now I will show you the technique how you can find out the disease, actually the diagnosis. Low now vaginal bleeding, lower abdominal pain. Now first find out the triad: vaginal bleeding, lower abdominal pain. Okay. And she has gone months without a menstrual period. So amenorrhea, vaginal bleeding, abdominal pain. BP is normal, not ruptured. Beta-hCG is higher, and transvaginal ultrasound is done. Patient is hemodynamic stable. Transvaginal ultrasound done, and no, not visualize an intrauterine pregnancy. So looks like ectopic pregnancy. What should you do? You should do a repeat beta-hCG. Repeat quantitative beta-hCG. Repeat quantitative beta-hCG. If beta-hCG is more than 3500, repeat beta-hCG with transvaginal ultrasound in 2 days. If it is less, then repeat beta-hCG in less than 2. So repeat beta-hCG is a must. Okay, now last two question. If we look at this question, positive pregnancy 5 weeks of gestation, so amenorrhea, uh, breast tenderness, uh, no dysuria, vaginal bleeding and cramping is present. Beta-hCG is 1100. Repeat beta-hCG is um, 1000 1370. So this increase is not more than 35%. It should be less than 35%. So repeat beta-hCG is less than 35%. It looks like so it looks like ectopic pregnancy. So if repeat beta-hCG is less than 35%, so looks like mm, looks like ectopic pregnancy. And in ectopic pregnancy, as this patient is hemodynamically stable and this patient has no other contraindication, so we can give Methotrexate. If we look at this question, positive pregnancy test, seen vaginal spotting, beta-hCG is 3033, transvaginal show a thickened endometrial stripe, no intrauterine pregnancy. No intrauterine pregnancy. A repeat beta-hCG is 3582, not more than 35%, and ultrasounds are unchanged. No pregnancy in the intrauterine cavity. So it looks like ectopic pregnancy, and DNC is performed. And after DNC is beta-hCG is declining. So looks like ectopic pregnancy. So abnormal rise in the beta-hCG less than 35% in 48 hours in this patient indicates either a non-viable intrauterine uh, a pregnancy or ectopic pregnancy. Because viable intrauterine pregnancy is unlikely, an abnormal rise beta-hCG can undergo DNC, which determine pregnancy location and intrauterine content. An abnormal intrauterine pregnancy includes a recent complete abortion, will have chorionic villi. An abnormal intrauterine pregnancy, including a recent complete, an abnormal intrauterine pregnancy will have chorionic villi, and a finding consistent with intrauterine placental development. In contrast, intrauterine content associated with ectopic pregnancy will have intrauterine pregnancy will have chorionic villi, but ectopic pregnancy will have no chorionic villi due to extrauterine pregnancy implantation, and beta-hCG is rising less than 35%, and DNC is confirmatory. DNC is done, and in DNC there is no intrauterine content, so mm, it looks like ectopic pregnancy. Okay, okay. So that's all about ectopic pregnancy. If you like my video, please share and give thumbs up and pray for me.